I, Dr. Ramkumar Srivastava, will give you the information about the TMJ dislocation. What are the causes and the treatment of this disease? We have to tell you about this condition. The history of TMJ dislocation started with the Hippocrates. He described dislocation and its treatment in 5th century BC. This TMJ dislocation is very common in female, about 57%. The bilateral cases is more common than the unilateral, and the percentage is about 71%. What is the classification of the dislocation? The first one is the subluxation, an overextension of disc condyle complex on opening beyond the eminence, which can be reduced by the patient. So this is the condition in which no treatment is required and the patient reduce the condyle into the normal position without any effort. Joint dislocation, a dislocation of entire disc condyle complex beyond the eminence combined with the inability to return passively into the fossa. In this type of the condition, the treatment is required. Hypermobility of TMJ characterized by excessive anterior movement of the condyle at maximum mouth opening without strain or symptoms. In this condition, the surgery is required. What are the causes of the dislocation? These are the causes: the overextension injury, yawing, vomiting, white biting, seizure disorder, extension trauma, dental extraction, intubation during general anesthesia, endoscopy, forceful overextension and injury to the mandible. Dental extraction. In the dental extraction, the dislocation of the joint can happen. This is because of the overextension of the mouth, or if you are asking the patient to open the mouth widely for a longer duration, this can result into the TMJ dislocation. Intubation during general anesthesia. In this condition, when the anesthetic opens the mouth widely for the introduction of the endotracheal tube, then there is chances of dislocation of the condyle. The other causes of the dislocation are lost vertical dimension, occlusal discrepancies, internal derangement, disynchronous muscle function, psychogenic, this is the habitual dislocation, drug-induced, and the most common drug is the phenothiazine. This is the normal closed position of the condyle within the articular fossa. This is the open position of the condyle with the articular fossa. If you are seeing the diagram, you can see the condyle is just at the tip of the articular eminence. This is the radiograph of the position of the articular disc. If you are seeing the articular disc which is blue in color, then you can see that the articular disc is at the tip of the articular eminence. The dislocation of the condyle may be unilateral or bilateral. The other types are acute, chronic, recurrent, habitual, and long-standing. In the acute condition, the immediate reduction is required, while in the cases of the chronic, the surgery is required. Classification based on the position of the condyle in relation to the articular eminence. Type 1. In this condition, the head of the condyle is directly below the tip of the eminence, and this can be reduced automatically. This is the normal condition. In the type 2, the head of the condyle is in front of the tip of the eminence, and this is the cause of the dislocation. In type 3, the head of the condyle is high up in front of the base of the eminence, and it is very difficult to reduce this type of the dislocation. Then the surgery is required in this condition. What are the clinical features of the bilateral dislocation? Inability to close the mouth, excessive salivation, pain, difficulty with speech, protruding chin, a distinct hollow in front of the tragus, open bite, tense masticatory muscles, pain in experience in the temporal fossa and not in the joint. In the unilateral dislocation, the mandible swing away from the side of dislocation, open bite on the contralateral side, that is on the opposite side. Occlusion is protrusive, the mandible goes in a forward position. A hollow just in front of the tragus on the ipsilateral side, that is on the same side where the dislocation is present. This is the clinical presentation of the unilateral dislocation. The mandible swing away from the side of the dislocation. You can see in the diagram the deviation produces a bilateral gross open bite on the contralateral side. Occlusion is protrusive and hollow. If you are feeling with the finger in front of the tragus, then you can feel a hollow on the same side. Bilateral dislocation, the mandible is positioned forward and movements are restricted. Gagging of the posterior teeth with anterior open bite. The hollowness can be felt on both the preauricular region. If you are feeling with the finger, then you can feel this hollowness. Associated muscle spasm contributing fixed position of the condyle. This is the radiographic examination. If you see the radiograph, you can see the condyle is just below the articular eminence. This is the normal condition. What is the treatment of the dislocation? Especially in the cases of the acute dislocation, this requires immediate reduction for relief of pain and anxiety which is present in the patient to prevent damage to the structures around the temporomandibular joint area. Reduction and immobilization for 4 weeks will allow damaged joint capsule, disc and ligament to heal. In chronic cases, treatment usually consists of exercise to gain better muscular control and restraint of opening. Once the dislocation has been achieved, the management thereafter depends on an accurate diagnosis and an understanding of etiology, including local, systemic, and psychologic factors. The reduction of dislocation is a problem due to resistance of the spasm of the muscles. Initially, attention is to reduce tension, anxiety, and muscle spasm. This is very important. Before going for the manipulation, you have to give some tranquilizer or the medication to reduce the muscle spasm. Otherwise, it is very difficult to reduce the mandible into the normal position. This can be achieved by the following methods: reassuring the patient, massage the area, tranquilizer or sedative drugs, and after that you have to go for the manipulation. The longer the duration of dislocation, the more difficult is to reduce it because of the muscle spasm. It is very difficult to reduce the dislocation if it is of a longer duration. Distal manipulation, this can be achieved by manipulation under oral painkiller, and along with this you have to give the sedative either orally or intravenous. Local anesthetic injection into glandular fossa and then manipulation. This is the best way by which you can manipulate the condyle into the normal position. Manipulation under GA with muscle relaxant. This is the last option if it is not possible that the reduction can be done under LA with sedative and the painkiller, then you go for the GA with muscle relaxant. Distal manipulation, you can see these two diagrams. First was given by the Digman and Netwig, and the second one is the Uranose method. The Digman and Netwig method is the easiest one, and you can manipulate the condyle into the normal position by this method. The manipulation under GA with the muscle relaxant and manipulation under either oral or IV sedation. So these are some of the methods by which you can digitally manipulate the mandible. Digman and Netwig recommended use of local anesthesia based on the theory that dislocation is maintained in that position by muscle spasm secondary to painful stimuli arising from the capsule. On injection into the glandular fossa or the muscles of mastication, sensory reflex mechanism of the joint is blocked and the muscle spasm is overcome, and then you can easily manipulate the condyle into the normal position. What is the method of manipulation? The patient is asked to sit upright in the dental chair. The operator has to stand in front of the patient. The thumbs of the operator are covered with gauze or a protective covering. Now the thumbs are placed on the occlusal surface of the lower molars and fingertips are placed below the chin. The posterior aspect of the mandible is depressed inferiorly while the chin is elevated anteriorly to depress the condyle below the articular eminence, and then backward pressure is applied to push the entire mandible posteriorly. So, in this procedure, the downward and backward movement of the mandible is important. By this maneuver, you can reduce the mandible into the normal position. You can see in this photograph how you have to digitally manipulate the mandible. Push the thumb on the posterior part and the fingers on the chin, and by the downward and the backward pressure you can manipulate the mandible into the normal position and close the mouth. Then you have to apply the barrel bandage to support the mandible for 24 hours. You can also apply the intermammary fixation for 4 weeks to prevent the further dislocation of the condyle and reduce the muscle spasm. What is this non-surgical treatment of the dislocation of the condyle? The medication, non-steroidal, anti-inflammatory drug, muscle relaxant, and steroids. Distal manipulation, psychological management, physical therapy, isometric exercises, occlusal therapy, correction of occlusal interferences, restoring the vertical support of the occlusion. This can be done by the dental surgeons. Intermammary fixation can be done for 4 weeks. Injection of sclerosing solution in the temporomandibular joint, capsule, and ligament and bilaminar tissue with or without arthroscopy. This is also beneficial to fix the muscles which are in a tension, and there is chances of some fibrosis which may reduce the chances of dislocation of the condyle. Chemical capsulorrhaphy to induce fibrosis and restrict joint movement. 3% sodium tetradecyl sulfate or blood, sodium silate emulsion in oil, sodium morolate. These are some of the solution which you can inject into the temporal joint capsule. And by the fibrosis, you have to restrict the joint movement, and the further dislocation of the condyle cannot be possible. Immobilization of the mandible is important to prevent early stretching of newly formed fibrous tissue, inability to predict the amount of limitation. Chronic dislocation, the conservative line of treatment should be considered for not very helpful for non-surgical procedure. Then you have to go for the surgical management in recurrent cases. This is the chronic dislocation, and in this case you have to go for the surgical treatment. What is the surgical treatment? First is the soft tissue procedure, plication of TMJ capsule and ligament, lateral pterygoid muscle myotomy, temporal muscle myotomy, suturing of the articular disc anterior to the condyle. The second one is the removal of the obstruction. In this, the procedure is aminectomy. Third is the creation of translatory obstruction. In this case, the first option is osteotomy of the zygomatic arch and down fracturing it below the articular eminence, and this procedure is known as the Daughtry procedure. Bone graft to articular eminence, metal implants on articular eminence or arch area. The fourth one is the tethering or anchoring, placing a non-resorbable suture through the condyle and suture it to the root of the zygomatic arch. The fifth one is the mandibular osteotomies, condylotomy, vertical oblique osteotomy, high condylectomy. These are some of the surgical procedure, and this is especially for the chronic one. But for the acute dislocation, the immediate reduction of the condyle is important, but in the chronic cases, you have to go for the surgical procedure, and these are some of the surgical procedure by which you can reduce the mandible into the normal position. Thank you.